A very warm good morning, everyone. Without further delay, I would start with my topic. My topic for the presentation is glue dial. So as we begin, I'd like to start from the indications which we come across in daily practice. Starting from posterior capsular rupture, zonular dialysis, subluxated lens, progressive systemic conditions, nucleus drops, IOL drop, or even endothelial keratoplasty or penetrating plasty with an unstable bag. Starting from the basic instruments that are required for the glue dial surgery, basic vitrectomy set of 23 gauge, glue dial marker, glue dial forceps, a trocar AC maintainer, 3-piece IOL of your choice, and fibrin glue, or can be done with sutures. Once a complication has occurred, how we start is first we suture the wounds if it's a phaco tunnel or an SICS incision, followed by the insertion of a trocar. According to your choice, it can be an anterior trocar AC maintainer or a posterior posterior trocar. Starting from the steps, in a very stepwise approach, we start from the scleral flap marking. This is done with the help of a scleral flap marker, which helps in exactly identifying the scleral flaps 180 degrees apart, which is followed by making of partial thickness scleral flaps using a crescent blade about 2 by 2 mm. This glue dial offers an advantage that it can be performed horizontally like temporal or nasal, or vertically in case of excessive white to white. This is followed by making of sclerotomies below the scleral flaps using a 22 gauge sclerotomy needle, making sure that when we enter with the sclerotomy needle, we should not hit the iris, otherwise it might cause iris bleed. So we should make sure that when we are entering the eye, it should enter vertically down, and then make it horizontal once we have a giveaway or a loss of resistance, as shown in the video. This is followed by insertion of the vitrectomy and thorough anterior vitrectomy or pars plana vitrectomy if desired. This is followed by an easy insertion of a 3-piece IOL through the phaco tunnel or the SICS tunnel using a 3-piece foldable or a non-foldable IOL. While insertion, we should make sure that we are following a sign which is known as the lucky 7 sign, in which we hold the first leading haptic with the MST forceps, and once we have a good grasp of the leading haptic, it is brought out through the sclerotomy, sclerotomy space. This, once we've externalized the first leading haptic, this is followed by something called as a handshake technique, in which it can be assistant dependent or non-assistant dependent by using 2 MST forceps, in which the trailing haptic is transferred from one hand to the other hand without any damage to the haptics or kinking of the haptics. This is followed by externalization of the second haptic outside the eye. As shown in the video, we first grab hold of the first haptic, followed by transfer of the haptic to the other hand, and then we take the first MST forceps through the sclerotomy and externalize it. This is followed by formation of the interscleral chariot tunnels using a 26 gauge needle under the scleral flaps, and followed by the haptic tucking into this Gabor chariot tunnel. While doing the haptic tucking, we should make sure that it is in circumference to the limbus. If it is outwards, it can distort the haptics and cause mild kinking. This is followed by the addition of fibrin glue, which helps in proper sealing of the scleral flaps as well as the conjunctiva. This is followed by the hydration of the wounds, or if desired, we can always make sure that we are closing it under suture. This is the post-op image that we usually get in a non-complicated or even in complicated cases, making sure thorough vitrectomy and wash is done. So in summary, the first step is we should first suture the wound so there is no excessive vitreous leak or trapping of the vitreous in the wounds, followed by placement of an AC trocar, maintainer or posterior trocar infusion, fashion out scleral flaps as desired, followed by sclerotomies, anterior vitrectomy, externalization of the 3-piece haptic IOLs, tucking of the haptics in the Gabor-Chariot tunnels, followed by insertion of pilocarpine to make sure that the pupil is round and circular, and close it. Thank you, sir.
Doctor, it is just technique which they accepted this is the technique. You don't compare with other techniques of the secondary IOL. So it is just a technique, it's good enough.
Yes.
Tell me the one biggest drawback of the glued IOL. Does it have a life? Does it carry risk of some kind of serious infections?
So as long as we have done hundreds and thousands of patients, the infections only if...
Not infection, I'm not talking of infection. Because you are covered it completely.
Yes.
So scleral flap must be covered. I do secondary IOL, but with the scleral fixation,
Yes.
the sutures, and then cover completely. So there is no extrusion at all of the loop.
Yes, sir. Yes,
That
sir.
was
There
the
is-
biggest complication of extrusion.
Yes, sir.
So but glue has a life. It can melt away and it can fall down. What I'm saying is just, if you could have compared with other technique of the secondary IOL,
Yes, sir.
there will be no it is better or not. You
Yes.
describe the technique, this is no technique.
Yes.
You have done it well, your guide or whatever Masterji has done well.
Yes, sir.
So technique is sound, but it has a drawbacks
Yes.
compared to the scleral fixation. Of course, there are many which fix them inside only without
Yes, sir.
opening.
Yes, sir. We can just suture the flaps as well,
But,
making sure that the...
Anyway, a good one. So glued one IOL is all right, and
The cost of the glue is one factor, so that is...
it carries the cow disease and all those so many things, HIV and the glued IOL have been found to carry some kind of viruses which are not detectable even in your labs
Okay.
so far. So, but technique of course is done, this technique is done.
Yeah, there are other peoples who do lot of glued IOL. At least you should have compared your results with them. That is one thing. Another is like you have told externalize first haptic,
Yes, ma'am.
and then you can use the second haptic. But you definitely have to make sure somebody is holding the already taken,
either we-
or put one
Plastic tag.
plastic tag
Yes,
kind
ma'am.
of thing. Otherwise, definitely it slips.
Yes, ma'am. If possible, the assistant can hold using a McPherson,
Correct.
or we can put a like we use a IV tube cuttings
Exactly
to just
that,
use
and
it
then
as a
put
tag.
it as sleeve kind of a thing so that it holds.
Yes, ma'am. With time, it does come a little easy, but
It
in the
does
beginning,
happen,
it
but
does.
still, when you are trying
It's
to
always
get
better.
the MST through the things, it can happen.
Yes,
That is one thing. Yeah.
Core cannula or anything, anti-chamber maintainer, standard one really for all, I virtually advocate it for any kind of surgery, even this secondary IOL also.
Yes, sir.
Because your chamber remains well,
Yes.
and your vitrectomy should be thorough.
Yes, sir.
That is what is very important.
Yes, sir.
And of course, vision and all that depends on so many macula and all that things. But technique is accepted.
Yes.
Thank you so much.
Thank you, sir.
Arnav, you didn't show us how you put the haptic in the tunnel after exteriorization.
Okay, sir.
How
I do
did
have
you-
it in the video. Actually, there was some problem in some of the videos being played. So what we do is we use a normal 26 gauge needle, and through close to the limbus, as close to the limbus and as close to the sclerotomy space, we make like a horizontal incision parallel to the limbus, and using a McPherson forceps, it is guided into the Gabor-Chariot.
Since you are showing all steps, this step has not
Yes,
been
I
shown.
think it's maybe
there?
skipped in. It's
Okay,
there, sir.
okay.
It's there.
And it's very difficult to show a technique which takes more than half an hour to show in 4 minutes. It's really difficult. Okay, thank you.
Thank you.